California that I got to manage, firm to run.
You have a job you actually have to do?
But this is my hobby, so I'm having a good time out here, though.
Well, you're good at your hobby. And for those of you that were not able to come to our earlier event at the Citrus Club in downtown Orlando, Project Opioid, of which I am the founder, along with a lot of business leaders, faith leaders, and others in Central Florida, put on a big community event that Harry flew in from his offices in Southern California to help give his national perspective on a Central Florida and Florida report that was just issued, the Prescription for Change. I think we pretty much did steal that from you, although I didn't realize I stole it until I saw your book again. So we're going to give Harry full credit. It's a tagline in his book. But what is the prescription? What are the changes Central Florida needs to make on the opioid crisis? We just released a study. We're going to send out another email if you didn't get that study, making sure you have it. That study was with the University of Central Florida. Looked at over, Harry, 71 data sets, interviewed over 20-ish of the top experts in America on the opioid crisis, and then looked at some best practices around America, put those three things together, and a pretty clear framework emerged of what Central Florida and really the state of Florida needs to do to make progress on the opioid crisis, save lives, reduce addiction. It was a tough report. Now, when you read it, did you wince a little?
No, I was impressed with the report. I thought you really have done more already to uncover what's going on locally than pretty much any region of the country. And I've been going all over the country with the book, talking to people. So I was very impressed with the data. I'll talk about what surprised me, what didn't in the data, but I thought it was terrific stuff.
Wonderful. So Harry is going to take a few minutes. For those of you that were in our presentation earlier, you've heard of some of this, but he's got more time now to dive into the details. But if you didn't hear Harry's presentation earlier today at the Citrus Club, Harry has his thoughts on the opioid crisis in Central Florida, in Florida, and around America, and he's going to talk about those and walk us through his presentation. As always, if you have questions during one of our webinars, you can click on the question box on the bottom of your screen and ask a question. We'll answer questions in real time. And Harry, take it away, my friend.
Fantastic. First, it's great to be with you. I wanted to say one thing, on this title of A Prescription for Change. I actually love that you used that. The subtitle of my book was United States of Opioids, a prescription for liberating a nation in pain. And I wanted to share with you, I called today A Prescription for Opioid Progress. So when the publisher originally was putting a title on the book, Forbes suggested to me The Making and Unmaking of America's Deadliest Health Disaster, more of a historical title, and I specifically chose, I liked the proposal to use a prescription because it's really about action, and I have to, as we go through today, that's the thing that has distinguished for me Project Opioid more than anything I've seen around the country.
Well, we appreciate that, and your insight has been key over the past few months in helping us shape what is the prescription, because ultimately, if I have a qualm at times with this discussion on the opioid crisis, it's what does it matter what we know if we're not saving lives, right? So that's why I love what you're doing, and I'm so happy that you were a part of it, have been a part of it.
Fantastic. All right, so I'm going to take everybody through the presentation that I gave quickly this morning. I'll do a little more relaxed right now for you. I really wanted to hit 4 points. I wanted to talk a little bit about the data from the Project Opioid report, some reflections on what I see that's really notable in the Central Florida data as compared to what we're seeing around the country and some of the research I did for the book. I wanted to talk about this issue of opioid singularity, which I have stolen from you.
Well, you're welcome to, because I think it's a very important point. By the way, Harry, they have the slides, so they're able to follow along with this as well.
Fantastic. So. And then sort of challenges we're addressing well, things we haven't, and where we go from here. So I want to start with, as a recap, the 12 points that came out of the Project Opioid report. Prescription opioids have flooded Central Florida. Illicit fentanyl is rampant in Central Florida. Narcan distribution is saving lives in record numbers. Treatment options are limited and not specifically focused on opioid use disorders.
That's a good way of putting that. I like that.
Medication-assisted treatment and counseling are the gold standard. I give you guys credit for calling attention. Number 6, fetal exposure to opioids neonatal abstinence syndrome, or NAS, is a problem that we need to be paying attention to. The prescribing, we need to reduce prescribing, but at the same time, that calls for alternatives, and I want to talk about that. Technology and innovation are needed to scale solutions to this crisis. The workplace is the new front line of helping those in need. Law enforcement need to lead in regional solutions. Targeted advocacy is needed for millennials and Generation Z, and regional response is important. Coordination, accountability, and results at the regional level are what's going to drive this. So if anybody doesn't have any time to listen to anything more, there you have it.
Harry, would you say that for most communities in America, that this is kind of the framework of what they have to work on?
I think this is, yeah, I wouldn't say anything different. There's nothing on this slide that I would take out for the West Coast, Midwest, East Coast. This is a great national map, and what I appreciate is you've put this together, Project Opioid, and Andre, you've put this together in a way that really makes it digestible and kind of walks people through the education process. And often, we're guilty in this conversation of jumping and assuming that people sort of know, are coming into it really well informed. And I appreciate the kind of organization here in terms of from just an educational and awareness standpoint, really useful.
For others that are watching this outside of our market, I would just also note, Harry, and if you can distribute this to anyone you want as well, these are all actionable. That's the idea here, is you can take any of these and put them in your community strategies, and if you can action these, you can make a difference. That's what I like about these as well.
No, I kudos. I really think this is a model that I hope will be taken out of Central Florida to the rest of the country. So let me get into, clicker's not working, but can you advance the slide for me? So
we can broadcast to the world, but we can't always get the clicker to work. So
there you go. Try it again.
Okay, great. Thank you. All right. So I wanted to just start with the national picture. So the opioid. When we talk about the opioid crisis, in terms of that first point about opioids flooding the country, I think it's useful. These are two snapshots from my book, Center for Disease Control data about the death rate in different parts of the country. And I always think it's interesting to look at where we were in 2000, which is sort of near the beginning of the crisis. And back in 2000, we just saw a little hot spot in West Virginia, in Southern Ohio, in New Mexico. There were little pockets of the opioid, but you would not say that this was a national crisis. There were 11,000 overdose deaths from opioids that year. And then this is the 2015 slide. There were, in that 15-year period, we tripled the death rate. The overdose death toll went to 33,000. Almost no part of the country untouched. Certainly bad in the southwest of the United States, bad in the Ohio, West Virginia corridor, in New England, Michigan, and down in Florida. So we started to see a real change. And then this is a 2015 slide. We're going to see the 2020 snapshot from CDC in a couple years. But where we are right now is 49,000 dead nationally from opioids. That's 70,000 is the all drugs. And then here in Florida, 4,200 statewide, 378 in Central Florida. So I two things I wanted to point out. I don't think Central Florida is, no one would call it a hot zone of the crisis, but part of what we see is that this problem is getting progressively worse and is a problem everywhere. And it's a strange thing because it's a slow-moving mass casualty event. And I just offer that to the point of opioids flooding Central Florida. That's kind of a national view.
Harry, it's hard for me to imagine if you were someone working on public policy in America or in Florida. It's hard for me to imagine another issue that has similar numbers in America, right? There's very few issues that see a fourfold, a fivefold increase in overdoses or an increase in their particular casualty rate, right? Isn't opioids a little bit unique as a public policy issue?
The important thing, I agree, the key thing is the acceleration in the increase is what's different about opioids. There are huge killers in America that are higher than opioids. Alcohol killed 85,000, suicide estimated to be 47,000 in America, but nothing is increasing at the pace of opioids.
McNuggets and Milky Way, I'm just telling you, saturated fats and sugar kill a lot of people. But what you're saying, and this is incredibly important for all of us, you didn't see the death rate for sugar increase in 4 years, double, triple. And so there's very few things that have moved at an accelerated pace the way opioid overdoses and opioid deaths have.
Yes.
So that's important, and we see more of why that is in this report and in your book.
And we're going to talk more in this presentation about sort of the full scope of the problem, but this one statistic I mentioned this morning that I think is a good way to frame this nationally is that we as Americans, we represent 4.2% of the global population. That's from the UN health report that came out last year on drug use. And we represent 12.5% of the world's overdose deaths. So this is not just a problem that's happening everywhere. This problem, we are essentially tripling our proportionate level of overdoses. If you assume that overdoses were the same across the world, you would be wrong. The case is that this is a much worse problem in the U.S. than in other advanced industrialized countries.
I don't want to get us off on a rabbit trail, but I think you talk a lot, and maybe we'll talk about this later in the presentation, about the bigger causalities that we need to look at. Is that a word, causality?
Yeah.
Okay. The bigger underlying causes of this opioid crisis, that beyond just opioids, which are a huge problem, and fentanyl, a drug for the ages as far as its lethal ability to kill those that take it. But beyond those factors, you talk a lot about the cultural underpinnings that are probably driving this crisis that really are represented in that chart that you show. I've seen you show before that drugs, overdoses, deaths are steadily increasing over multiple generations. Across all drugs. Again, I think the reason that's important is because when we look at the opioid crisis, we're going if we looked at in America a lot of different similar issues, America is much higher than other countries when it comes to those issues as well. A lot of public health issues.
Absolutely, yeah, and we can talk about it. Mm-hmm. I think the important thing to say here is that when we talk about the opioid crisis, one of the things I try to say in the book is we need to think about in terms of overdose deaths as a problem, addiction as a problem, and chronic pain, the pain epidemic in America as a problem. Mm-hmm. But the one that's the most sort of salient, that's distinct about America is overdose deaths.
Yep.
So, all right. So did I skip a slide? No. Oh yeah. No. Sorry. So I wanted to talk about sort of where we are. A key data point in the study was about the crackdown and the way that drug prescription is being reduced. There's a lot of sort of patting on the back, self-congratulation going on around the country in different places about the fact that prescription opioid overdoses are going down, and that's somehow a victory. And so I think this is something that your study, the Project Opioid, really does a good job with. And I think that I was really impressed by the way that you had the PDMP. It stands for Prescription Drug Monitoring Program.
Dr. Ward got that, and it's not even public. I don't know how that's possible.
This is data collected at state level, every state in the country, and so it's you guys went through this data. What was striking was the data is from Central Florida. The last 2 years, 2016 to 2018, a 31% reduction in morphine milligram equivalents, meaning the total dosage of opioids being prescribed statewide. The first 3 quarters of 2019, a 33% reduction from the first 3 quarters of 2018.
So Harry, and for everyone watching, these are compounded. So you had it's like when you go to Bloomingdale's and they say it's 33% off plus another 33% off. Well, it's not 66% off, but it's not 33% off.
Right.
So the opioid prescriptions, for those of you that don't know what this prescription data is, this is the data on how many prescriptions are written and the quantity of those prescriptions. This said in 2 years, between 2016 to 2018, you saw a 31% reduction in prescription opioids, legal opioids, not illegal opioids. But then just in a shorter period of time, roughly a year, you saw another 33% reduction. I'm hearing these conversations in the industry of a 50% reduction. That's about 50%. And so, Harry, this was really concerning to us for a lot of reasons, but mainly because what we heard from our experts in our interviews is that if someone has a dependency to opioids, whether they have strong social determinants or whether they don't, either way, boy, that's going to be a really hard challenge for them physically to simply just cold turkey, hey, sorry, all those opioids we're giving you, tough luck, now just suck it up and feel better. Whether chronic pain is their issue, or whether they simply now have dependency to opioids from being overly prescribed, either way, the dope sickness, if you don't know what dope sickness is, I strongly urge you to take a little bit of time to look into what it's like to withdraw from opioids. This is a huge problem if we see, as you're saying, a victory in just reducing opioids. I think let me clarify this, because this is probably the most controversial part of this data. Make no mistake about it, we poured way too many opioids into this community, into the state, and into America. And so this reduction makes a lot of sense idealistically and hypothetically. It makes a lot of sense because we should make it harder for people to get on opioids, right?
Yeah.
But Pandora's box is already open. You have hundreds of thousands of Floridians, millions of Americans that have dependency to these drugs. You can't just pull the lever back. That's our concern.
And I wanted to just put some color on that for you. What I've observed is, I have a picture up on the screen of Dr. Lisa Tseng. She was probably the most famous physician in California who was prosecuted for pill mills. Mm-hmm. Florida was known around the country as an epicenter of the pill mill phenomenon, where doctors were basically allowing unscrupulous distribution. People would just come to get drugs. And what we've seen is a lot of the pill mills, there's been a crackdown, and I'm going to show you a slide on a couple slides down which kind of show it. But there was already a slowdown in the 2000s. The pill mills were largely closed. And what's going on now in this reduction is ordinary physicians who were prescribing opioids are basically saying, you know what, it's not worth it. It's not worth me taking the risk with my medical license to keep prescribing opioids. So this is a troubling number, and I want to talk about why.
Yep. Yeah. And they back up what Harry's saying. One of the things that's so important about the way that we as leaders look at this reduction on opioids. Let me recap that. In Florida, if you're a Florida person, we have data showing roughly a 40% reduction in prescription opioids, not illegal opioids, in the better part of, let's say, 2 years, 18 months, without a response for those individuals, a wraparound response to meet those individuals with a diversion of some sort to help them. There's been no concerted effort to do that. That's why we feel that's dangerous. But again, the idea of less opioids on its own is a good thing.
Yeah. So just to highlight, sort of, this is a problem going on nationally, and to frame it, the most interesting thing to me was that in April of 2019, the Food and Drug Administration, the FDA, which has been on the aggressively trying to limit bad behavior, aggressive marketing by opioid manufacturers, had basically put out a warning that doctors were pulling patients off of opioids too quickly and required new warnings that patients couldn't be suddenly discontinued. And that is a sign to me that the reduction of doctor-prescribed opioids has actually gone too far. So we've got a problem of both too many opioids out there, but people being pulled off of them too fast.
Yeah, Harry, let me give you my commentary as one of the authors of Prescription for Change. Kendall's job was to deliver the data. Some of us here on our team, our job was to help give color to that data. For those of you out there that are like, this is not fair, we need to stop pulling back opioids and people are in pain. Listen, I'm not going to argue with you about that. Here's what I'm going to tell you, though. You're not going to stop this. You're not going to stop these reductions in opioids because, Harry, it's the marketplace that is causing these reductions. It's not laws that have passed. It's not doctors who go to write a prescription and the computer says, no, you can't do that anymore.
Right.
It's doctors, hospitals, pharmacies, pharmaceutical companies, insurance companies who all look at the Purdue Pharma lawsuits, who look at the Johnson & Johnson lawsuits and go, yeah, opioids is bad business now. So it's a marketplace movement, and that retraction has come from the marketplace turning. The reason that's important, folks out there, and Harry, I'd even say this to you, is because you can't stop the marketplace when it moves. So the only thing we can do is create substitutes or alternatives. But that, again, in the same way that we couldn't at the time stop, maybe we could have, but we didn't, there was no stopping the flood of opioids. The recession, the water is now going back the other direction because the marketplace is doing it. It's happening organically. There's not going to be a way to say, to necessarily pull that back.
Yeah.
The only hope we have is to give people alternatives.
So,
I agree with this, though, that it's happening too fast. Again, it's a difference, though, between the marketplace adjusting and some kind of legislation that could then be reversed.
right. All right, so this was an important slide that I showed. Centers for Disease Control put this slide out. This is my commentary on it. This is a slide that sort of shows the death rate of the opioid crisis in 3 waves. And what it shows is we have a top line here, which is prescription opioids, and that's that line that triples from 99, 2000 to 2015. And that is a line that if you see, it was the death toll was going up, but then it actually hit a peak in 2010, it dipped, and then slowly, it's going up slowly. What we see, and this goes to your market comment, is we have this dotted line behind that was heroin. Some of that was the brown powder heroin being used in Appalachia. Some of it was black tar heroin. But that line it begins in 2010 as just as the government crackdown on doctors is leading to less prescribing even then, 9 years ago, the black tar heroin fills the void. It goes to this market concept. And then we get this black line, which is really not moving much at all until 2013, and that is fentanyl. And what we see is that the market, as we have cut back on prescription opioid availability, heroin, there was a moment for the heroin dealers and the heroin traffickers, but really the big opportunity has been fentanyl flooding in from China and Central America, and 40,000 people dead of fentanyl. And the fentanyl deaths, so the prescription opioid deaths are actually in some states are flat or even going down a little bit. The fentanyl deaths are skyrocketing, 90% year-over-year increase.
Yep.
40,000 dead in North America last year.
So if you're someone out there and you are looking at this with fresh eyes, fentanyl is really the driver of this crisis in a way that, these lines, Harry, there's some flow to them, but fentanyl takes it to a very different place when it hits the streets. But this is important, fentanyl did not hit the streets in high quantities the way we see it now, really till 2013, 14, 15.
Yeah, and just to be clear, we're talking about illicit fentanyl here, not the hospital-grade fentanyl that's sold at the Duragesic patches.
Correct. So illicit, Breaking Bad style fentanyl. A lot of people get that reference. Someone somewhere, probably in China, Mexico, in a clandestine lab, have made this rough-shot version of fentanyl, which is incredibly powerful and dangerous.
Yeah. By the way, I encourage people to read the book Fentanyl Incorporated if you'd like to see resources on that. So that brings us to this concept of opioid singularity, right? The concept of opioid singularity, right here, when we remove prescription opioids without offering alternative treatment, we are driving the people who are dependent on opioids to drastic measures, right? We're turning people, I have 3 S's here, suffering, suicide, and...
Come this way. This one's perfect. There you go.
Suffering, suicide, and going to the street for drugs, right? The singularity is a term from Raymond Kurzweil, a science fiction author, who talks about the way that we are living in a period where information is accelerating the pace of change. And what we're talking about here is a degree of if people think the opioid crisis is bad now, this phenomenon of driving people to the street is going to make it much, much worse. Yeah,
the idea of the opioid singularity as a theory in the opioid crisis came from some work I did with partners in the tech world, and obviously. And I had come from a meeting on the opioid crisis, and this conversation of the technological singularity was being talked about. And what struck me was that the singularity from Kurzweil's world is multiplication factors that equal a math equation that we can't see past a horizon. And go back to your slide really quickly. I want to show everyone this because I think it's important. I'm walking off camera here, but it's gonna be fine. So if you think about, I've got my pretty little jars here. If you think about everyone in this beaker here, yeah, you can set that there. This beaker here, let's say that this is a 2,000 milliliter beaker that holds these little plastic pieces. Let's say that this, Harry, you can hold that a second. This represents 66,000 Central Floridians who have seen this trend in their world, but they're using heroin, using prescription opioids. They're using some kind of opioid. This group, this group of people is using prescription opioids. This would represent the treatment options that are available currently in our community. As you start pulling all of these numbers, this is really important, and I'm gonna move on from this in a second, but this is critical. When you look at the trends that flow from 1999 to really 2013, these trends had numbers that were scary but pretty steady. They were steady. The factors of them were pretty steady. Fentanyl comes on the scene here and throws a potency at those using that drives the death rate skyrocketed up, right? And Narcan comes on the scene right around the same time and is probably saving many more. This line would probably be up here if not for Narcan.
Yeah.
But that's not the end of the story, because now we have a new factor. And that new factor is the idea that we're now pulling back opioids at a pace that really is unprecedented, other than the pill mill crisis that happened in 2008, 2009, where there was no fentanyl on the streets. So what happens, Harry, this is the math of it, when now with fentanyl on the streets and very little treatment available, we start trying to take individuals and divert them into this system. You'll get a few, but ultimately what will end up happening is the smallest percentage of transference of folks who have dependency on prescription opioids into a broken and inadequate treatment model will not get these folks help, and the majority of these people will have a very negative consequence. Very few of these people will just suck it up, buttercup, and be okay. So that I just want to show everyone that, because I think that helps kind of give an illustration of what we're really up against. How do we, not all these people are going to get their opioids cut off, and not all these people will turn to illicit fentanyl into heroin. But if the smallest amount do, this problem, there is no place for them to go. So and if it happens at a higher level, Harry, the reason again we use this opioid singularity idea is there's a death rate that is with fentanyl on the streets having not gone down, with us cutting people's opioids and giving them no alternatives. There's a scary horizon in this country that might not last forever, but could see the death rate skyrocket in a way that is almost unimaginable. We're not saying that's going to happen, but we're saying we don't know what's going to happen beyond this horizon.
Well, it just increases the urgency of doing something here. All right, so I wanted to kind of move to what are we doing to solve the problem. And one thing that's being done well here in Florida that is nationally saving lives is Narcan. Narcan is a brand of a drug called naloxone. This is the overdose reversal drug, and it's being distributed to save lives in record numbers, right? This has really, I wrote in the book about how this has really transformed healthcare, because all of a sudden we're asking the police, we're asking first responders, not just to get people to hospitals, but we're actually in the field administering it, because if you can give it to people while they're still breathing, you can save lives.
Harry, I know this is pure speculation, what I'm about to ask you, but I mean, it's hard to imagine how many people would be dying a year without Narcan, right? I mean, is it? I don't have. I'm not going to. The numbers would be up dramatically. The numbers would be up dramatically if not for Narcan.
Yeah, hundreds of thousands of lives, I would estimate, are being saved.
Yes.
The other big solution that I think Project Opioid is calling attention to in an important way is medication-assisted treatment. Now, when we talk about medication-assisted treatment, or MAT, we're talking really about three different therapies. Suboxone, which is one of the most popular brand of a drug called buprenorphine, Vivitrol, which is the brand of a drug called naltrexone, and methadone. So basically, what we're seeing is Suboxone is the primary form of MAT, medication-assisted treatment, that is being used effectively for opioid relief. What's powerful about Suboxone and other forms of buprenorphine is they can be given almost right away to a person who was addicted to an opioid, you don't have to wait for that person to detox.
Just a few hours after.
Yes.
They could be in an emergency room, they overdosed, they were brought back with Narcan. A few hours later, you could give them buprenorphine.
Yeah, and that's distinct, by the way. The naltrexone, just for comparison's sake, can only be given to people. It will make people violently ill if they take it before they've fully detoxed, so you can't give it right away. So what we've seen is that because it can be administered very soon after, we can transfer people very quickly who were addicted to Suboxone or another form of buprenorphine. And what we're seeing is it reduces overdose deaths, it reduces the spread of diseases and violent crimes, and it really improves treatment outcomes.
Harry, I think a lot of folks that were at our meeting today and a lot of folks in their community who hear about these three drugs, if this was a beauty contest, let me weigh in on the beauty contest here. Buprenorphine obviously has people that love it because of its the easy ability to administer it and to get it out in theory to a massive amount of people in need. Its detractors would say you're substituting one opioid for another.
So I want to talk about that.
Okay, but I would say naltrexone, I was in a meeting in South Florida with some very credible people. I mean, not people that I had the utmost respect for these people. I had a behavioral health leader refer to Vivitrol as a miracle drug. And so this was not a dumb person. This was someone who's got years of work, years of time in this space. And so there are absolutely people that have put together programs where naltrexone and Vivitrol has been a tremendous help. And I would say, but the detractors of Vivitrol would say there can be a danger. Last thing, and I'll let you talk. Pretty much everyone hates methadone.
Well, so let's just talk about that. Methadone is a much older drug. Methadone is focused on heroin. Methadone has saved enormous lives, but methadone is an easily abusable drug, and it is a drug that has a real stigma attached to it. Frankly, a lot of the conversation around Suboxone and buprenorphine have been influenced by methadone. Methadone is there are people who are saving lives, whose lives are being saved by it. I had people today tell me that they work with people addicted to heroin who have been on methadone for decades and are functioning. They have families. They're holding down jobs. This all fits into the harm reduction approach as opposed to an abstinence approach. And so methadone is part of the solution. But I want to say something about naltrexone and buprenorphine. So the challenge with methadone is it is abusable. Several thousand people a year die from methadone overdoses every year. Suboxone has a ceiling effect, so people are not dying from Suboxone overdoses from buprenorphine. But it is a partial opioid agonist, meaning that people are it's triggering that receptor. It has a ceiling effect, so people are not getting high. They can hold down jobs. They can be fully functional. But that's the piece that people stigmatize.
It is an opioid.
As opposed to naltrexone, right. It's mild opioid. Naltrexone is an opioid antagonist, meaning it prevents people from getting high. So if you have naltrexone in your system, you will become ill, and you won't get high. You won't have any positive effect from it. So it's a way of getting people to stop using. But it has much more limitations.
And I will just say, Project Opioid in our research study, we endorse all three. And by the way, I know that sounds like a politically correct answer, but we really do. There's enough data to show that Vivitrol is incredibly effective in certain situations, and there's a lot of data that shows buprenorphine is important as well. So methadone, I would say we need more research on that. But I've heard enough stories to tell you methadone works for a lot of people.
Saving a lot of lives.
Yeah.
So the important, here's the data point that came out of the Project Opioid study that I think is important. First of all, we know that nationally, there was a Presidential Opioid Commission report put out in 2017, which made a comment that when you take all the forms of MAT combined, only 10% of addiction treatment programs, opioid treatment programs, were actually offering any form of MAT at all. The number today might be closer to 10 to 20%. But Florida has been in MAT desert. Central Florida has been in MAT desert. And so that's one of the real takeaways is we need much more MAT. Nationally, we especially need it here in this community.
Yeah, and some of our behavioral health providers and others didn't. This was something that people reacted some in the behavioral health community negatively. I just want to reiterate that Project Opioid is saying, and UCF was saying in our research, for thousands of people who may need MAT, there are very few options available. And most of those options, I use the word that I got a little pushback on in the Orlando Sentinel. Most of those options are not legitimate. So let me have a chance to retract that statement and absolutely not do that. They are not legitimate options, Harry. When someone calls a phone number to get buprenorphine that they believe they've been told from you and others can save their life, and they're told $3,500, and it's just a gateway to a detox program, or it's $1,000 a month, that's not a legitimate option for that person. And so a legitimate option is affordable and accessible, not a lot here in Central Florida or in Florida.
So I want to encourage people not to have this binary that MAT is good and the other resources out there are bad. The way I would encourage people to think is about MAT, thinking of MAT as a bridge to recovery. It's not, first of all, so let me just say, the reason we've seen so little MAT is there's a couple reasons. Number one, there have been enormous regulatory obstacles. Physicians are required to get a DEA waiver. It was only in 2016 that for the first time, physician assistants and nurse practitioners were authorized in federal law to prescribe it. And so part of the issue is regulatory. Part of this issue is the stigma that MAT was just another form of drug and not real recovery. And so I think we have to abandon that, but we also need to remember that millions and millions of Americans have been helped and are sustained by recovery community, and that MAT is not the end. MAT will address the symptoms, but the real work begins once you are stabilized and you can return to work, to family, to relationships. You still need to build a stable path of recovery in your life, and we all need that. People in addiction need that and know that, and so I think we should avoid casting aspersions. There's work to do to make sure that we're taking evidence-based approaches, but there is a lot of good work being done in the outpatient and residential programs out there.
Yeah, Harry, it seems like, and I love this slide, and I actually really like the way that you position this. We have to have this marriage between older 12-step programs, behavioral health programs, more traditional ways that we have dealt with alcoholism, other drugs. There needs to be a marriage of those good people in their programs with probably some adjustments that have to be made when it comes to harm reduction. Our study would say, you hear me say this like a broken record, you notice I get something in my head and I just say it and say it and say it. Fentanyl requires, in our opinion, in my opinion, a new look at harm reduction because of the statistical dangers when someone relapses and they're in an environment where heroin is present and now fentanyl is almost always present. Should we have always looked at harm reduction? Sure, Harry. But I would just say that now harm reduction probably is at a place where we have to say when someone has opioid use disorder, they're using illicit opioids on the street, how do we get them safe, and then how do we get them recovered? And instead of those two things being either or.
100%. It's a more inclusive vision. The bottom line is we want people to be using less. We want people to live, and this is a way of keeping people alive.
Well said.
All right, so I want to talk about, just very quickly, some of the other things. What else have we learned along the way? These aren't really part of the Project Opioid report, but a lot of other reforms that have come out of the government are happening a lot more slowly, and it's not a bad thing. It's just these are things on the horizon. More public awareness, more outreach and education, early intervention towards middle school and up, more training of physicians, because physician medical school training has long ignored pain and addiction, more innovation for alternatives to opioids, which we talked about, more interdiction to stop the flow of fentanyl and other drugs into the country, and better analytics, which again I give credit to for Project Opioid, but we just need a better system of understanding what's happening, because part of the problem in this whole crisis was we kind of missed it. We didn't have data to track drug overdose deaths. A lot of it got masked as heart attacks, and so that's some of the other work ahead.
Wonderful.
So I wanted to talk about what we aren't addressing, and I wanted to call attention in particular to two problems that were in the Project Opioid report. One of those is NAS. We don't talk about NAS enough. There is a child born every 15 minutes in America who needs to be weaned in a neonatal intensive care unit off of opioids because their mother was addicted to opioids. And this is a number that has gone up 500 to 600% over the past 2 decades. We now have this is a problem this is a problem nationally, and we don't fully know the consequences. It's not just about the suffering of innocent babies. It's also we don't know, and it's not just about the healthcare costs. We just don't know what the long-term implications are, and this really highlights to me the extent to which we need to focus on women, on mothers, and we need to find effective ways to reach people who are really in the depth of addiction in pregnancy. It's a huge problem.
Kudos to Dana Bledsoe and the team at Nemours Children's Hospital located here in Central Florida. When Project Opioid was first getting started in January, February of this year, they said, nobody's standing up for the babies. No one's standing up for these children. And so they're a huge part of our work, and they're not going to let us forget these kids. You know, Harry, something else to think about when it comes to neonatal abstinence syndrome is the idea that these children, we have no studies to show what are the long-term effects of these drugs on these children long-term. That's number one. And number two, there's a really weird moment right now where we're celebrating two things right now in this country and in our community and in Florida that I would caution us not to celebrate. We're celebrating the reduction of prescription opioids at a rapid pace, and we're celebrating this plateau of the death rate on opioids, which, by the way, I would say if you want to celebrate that a little bit, I'll allow you to. But what is masked inside of the plateau of the death rate is that in no way implies that less people are taking opioids. It just says that we have maybe found a way to save some of them using Narcan. So bringing that back to this, a way to really understand the opioid crisis using data as far as percentage of population would be how many neonatal abstinence syndrome children are impacted or born each year, because that's probably a more true number of the overall opioid crisis than just a death rate that may be jockeyed because of Narcan. The death rate's important, but I think this is that we could celebrate a plateau death rate and not realize how many people are affected by opioids in long-term ways, especially children.
So the other group I wanted to call attention to, also children who are the sort of unseen and the victims we don't talk about enough in this crisis, are the children who are growing up in homes with parents who are either absent because of addiction. We have parents incarcerated for addiction-related offenses, and we have a whole generation of kids who are really growing up either raised by grandparents or raised in the foster system. This is a real tragedy happening everywhere, and it's one of those hidden aspects of the opioid crisis that I also would encourage people to think about and pay attention to. It's something that we're going to be hearing more and more about in the coming years.
Hey, our study showed that the average age of someone who dies of opioids in Central Florida is 41.2 years. Harry, those are people with children. Those are people largely who have children. And so for every person that dies, we don't have this data yet, but we could estimate 1.5, 1.7, 2 children in each situation that are now one parent or in some way now both parents gone and exposed to the foster care system.
Yeah, a huge piece of the crisis.
So, again, something we've never seen before, that many children introduced to the foster care system all at once.
So I wanted to use our last couple minutes to just sort of talk in broader terms. We've talked a lot about overdose deaths. This is a Center for Disease Control graphic that I like because it just points out for each person who dies, we're talking about 10 people who are admitted to treatment for abuse, 10 people who are near misses. So we're saving lives. This is a typo on the slide. We're saving. Those are near misses of people who survive because of Narcan.
Okay.
We have 32 people admitted for treatment, addiction treatment. We have another 130 people who have a dependency, and then we have all these other people who are non-medical abusers. We have 1,000 people out there who have some level of dependency.
For every one death in America.
Yeah.
Wow.
So let's talk about. I want to talk about some big, high-level points that people should think about. One is the extent of America's drug problem. And by the way, kudos, Kendall Ward, Dr. Ward of Central Florida University, talked about this at this morning's program. And so the numbers are basically 1 in 12 adults. We're not even talking about the kids yet. 20 million plus Americans misused opioids, right, in the last 6 months. 1 in 12 misused a drug. 2/3 of those are opioids. That's about 12 million to 13 million people misusing an opioid, and only about 10% are diagnosed with a substance use disorder. About 2 million, 1.3 million people diagnosed with an opioid use disorder. Of that, again, about the 2/3 of all drugs. So this is important to highlight that this is a massive problem, and it's a problem with a lot of sub-varieties. You have a young population using opioids that's really distinctive, not necessarily out of pain, but using them simply to just kind of escape.
Emotional pain,
right.
Psychological pain.
Important point. Pain. We talk about pain a lot. In fact, my next slide is about pain. Is about America's pain problem. By the way, this is, again, adults, not kids. 1 in 5 adults in America, 50 million people, have experienced chronic pain in the last 6 months, according to the Center for Disease Control. 20 million, 1 in 12 adults say it limits most or all of their work or life activity. So when we talk about pain, we have an epidemic in this country. And again, this is worse than the rest of the world. And important to your last point, when we talk about pain, there's physical pain, there's psychosocial pain, there's spiritual pain. We're missing a good understanding of pain and how to treat it. And this is kind of a bigger problem overarching this crisis. No matter what we do, taking on opioid addiction and overdose deaths, until we get at America's pain problem, we're not really going to solve the long-term challenge here.
I encourage people to read the United States of Opioids. I think it's chapter 7 you talk about. Is that right? Chapter 7?
Yeah.
Is that right?
Yes.
Okay. I told my team I've read your book 5 times now, and I have. That's true. In chapter 7, he talks about aspects of America that we need to face beyond opioids if we're going to make progress on this crisis. He says, and read this in the United States of Opioids yourself, but we've got to talk about the fact that we don't take care of ourselves. We don't take care of ourselves. We are heavier. We eat bad. We don't sleep, and that causes a lot of us to be sick and to be in pain, and that might impact those that are a little bit older. For the younger folks, Harry, this is just my 2 cents. You look at the death rate among millennials, and you look at how many millennials are depressed and have anxiety. Harry, I'm 43. I would not want to be 25, 27 years old in this 2019 America. I think it's hard. There's a lot of societal factors on those who are younger, and the physical factors on those that are older. Those aren't going away unless we have a conversation about them. So
yeah, I would just say you absolutely point to these issues, ways in which Americans are less healthy, heavier, under a lot more stress, not getting enough sleep. With some of the things
financial pressures.
In the book, I talk about economic worry. How much of it is? It's certainly this crisis is worse in the places that have been hit the hardest with unemployment. How much technology is a piece, and those are pieces. I would encourage people to think at the deepest level. And I think this is helpful from a prevention standpoint more than how do you intervene. Because once somebody has an opioid dependency or addiction, they really have had physical and chemical changes. But in terms of thinking about prevention, it's not a mystery what keeps people on the path away from these things.
Yep.
It is about connection to others. It is about a sense of purpose. It is about feeling a sense of autonomy and a perspective on your own life, and being of service to others, whether it's through work or in volunteerism or otherwise. Those are the tools of prevention. We have to teach people a good sort of stress response coping mechanisms, and we also have to encourage people to understand how much the basic fundamentals of living a life of integrity actually keep you safe and keep your family safe from opioids.
So I want to go all the way back to something really quickly, because I think this will help round out MAT, which is incredibly controversial. Medication-assisted treatment might be the most important thing for someone who is overdosing and in danger of death to fentanyl. But it might be one of the least important things when it comes to the broader conversation of what's driving, from a societal standpoint, the opioid crisis. And so that's where I can appreciate both sides of those that look at MAT and say, well, it's not a long-term fix. Yes, but it will keep people alive, while as a society, or in that situation, we help someone figure out how to find a place of stability and health for the long term.
Yes. All right, so just some final kind of big thoughts on the work ahead. Number one, as Andre's display showed us, we have a massive problem in terms of the number of people who need help. We desperately need more resources, both for people in pain and for people who are addicted.
Yep, Harry, in our report, you can read that. We're gonna, if some of you are probably watching this on a recast that we're gonna send out to everyone tomorrow. The full report is in a PDF in this email along with your slides. But we are very, very specific when it comes to the need for more resources to scale up this many people who might need help into this little container. This little container doesn't work. You have to create outpatient MAT. The genesis might need to be MAT and outpatient. Harry, our report would say there's not enough brick and mortar to build inpatient detox to meet this many people's needs. So it's important that we have those, but we're going to have to look at new methodologies to
100%.
get there.
So the two takeaways from that point, and this is a good segue to my next slide, is our technology and peer recovery community, peer coaching. Technology is critical. We just don't have enough brick and mortar, as you said. We've got to use telemedicine, telehealth to get more resources to more people. And we also need to leverage peer coaching, recovery community, right? These are the people who have been the veterans in the trenches doing the hard work, and we need to put them more in contact with people who are open to recovery, and because I think these are going to be the only ways that we're going to be able to meet the scale of this problem.
Yeah, and let me give you one little Project Opioid opinion on this. When he says peer recovery, another way of saying it is affordable, because peer recovery can be a lower price point for someone who does peer recovery versus a clinical psychologist or a doctor of psychiatrics.
Right. And we're going to need all the doctors and the mental health professionals we can get.
All of them.
They're still not going to be enough.
It's not enough. So having, I had a group say to me, we need to be thinking about the opioid crisis a little bit the way we've thought about suicide prevention in America, with a little bit more outreach and a lot more good people on the front lines keeping people safe and walking them through that might not be clinicians.
Yeah. All right, just a couple other thoughts. First of all, one of the things I thought was really tremendous in the Project Opioid report, the calling attention to the need for law enforcement to lead. And when we say law enforcement leadership, we don't just mean incarcerating people and stopping trafficking. That's important, but also acting as a conduit to treatment. We talk about law enforcement assisted diversion, getting people who are just using drugs out of the criminal justice system and into treatment, and really trying to use, whether it's drug courts, whether it's a lead program, having law enforcement's leadership is so important.
If you don't know Dennis Lima, if you're watching this from another community, you need to get your law enforcement to hear what he's doing on the opioid crisis. I think he's a national leader on this topic.
Yeah, I was very impressed by his comments today, and encourage people to listen to him. So another piece of Project Opioid, really distinctive. I have to give you credit. I think that the leadership coming out of the employer market, out of the business community, is really tremendous. One of the things that we're seeing is we have a new front line in the opioid crisis, right? This is another example of that same point about scale. We've got to use the workplace not just to tell people to stop smoking and have them not listen, but to create effective resources for prevention, early intervention, and referrals to treatment, and a lot of work to do in making the workplace an effective new front line. That has not happened. The workplace has been a place where people are afraid to come forward, employers are afraid to get involved in employees' lives, to be perceived as big brother, and we've got to change it. We've got to create a culture of engagement in the workplace that looks at not only addiction and drug use, but also at mental health issues, at stress. And I think this is one of the things that's just beginning to change, and I want to credit Project Opioid for calling attention to that.
And we're going to be asking state leaders, business leaders around the state of Florida, and really around America to look at this next year in 2020. Harry, think how many lives could we save? How many lives could we help get back on track if our interventions with someone struggling with opioids started at their workplace instead of when they've overdosed and almost died in an emergency room? Harry can tell you the stats. If you now are overdosing, being brought back, you've been arrested, you're on street heroin, the journey to get that person back to safety and recovery, so much harder than if you can intercede with them earlier.
100%. But there's a lot more to say here about schools, about faith communities, but
Here, let me mention one last thing here that's super technical, and forgive me for this, but the other thing about the workplace is it's a captive audience. On the opioid crisis, if you're in another community working on this, it's great to talk about these one-off ideas or programs, but ultimately this is about what systems changes can happen. The workplace can create systematic and replicatable, then scalable options. That's why we really like it.
So important. All right, so just some final thoughts for you. I think what the answer to solutions, this is what I said in my book, it's also what Project Opioid has embraced.
Well, I did read your book 4 times, so.
Is this model of
5 times.
Community partnership and regional coordination. So what are we talking about? We're talking about bridging together the roles of law enforcement, our health systems, our mental health, behavioral health providers, our treatment programs, our recovery community, our schools, our workplaces, our faith communities, and our civic communities together in a regional model. That is the best hope that we have for a solution here. Healthcare alone is not going to solve this problem.
Correct. Healthcare also is only able to start addressing the problem at the very beginning and at the very end when people are overdosing. Everything in between is our big opportunity. So,
and this is really, and then finally, I wanted to just comment. You know, it's the opioid litigation is reaching a point of where we're very close to a global settlement. The lowest numbers we're talking about are approaching $50 billion. There's going to be money coming into the state of Florida and Central Florida, but I think the first question is what are we going to do with it? And then my final point here is that it's not going to be enough. Whatever amount of money comes is going to be great. We've got to make sure it's spent accountably and it's used to support Narcan, support MAT, support more resources on the ground. But it's still just the very beginning of this fight. We are in a long battle to actually bring down the death toll, to create effective treatment resources, and to address chronic pain. And that's my sort of ultimate point that I hope people take away.
Wonderful. Harry, is there any last kind of thoughts you'd give as we're wrapping up? How can people get a hold of you if they want to, come to your house and drink? How do you do that?
It's 5 p.m., so we're going to wrap up. People can find me at harrynelson.com. If you
can get the book on Amazon.
The book's on Amazon. I appreciate Amazon reviews and feedback. So yeah, please reach me. You can reach me. My website is here, harrynelson.com. You can reach me at hnelson@nelsonhardiman.com, my firm, and I welcome feedback and information. I think that the more learning we do together, the better chance we're going to have in the work ahead.
Harry Nelson, author of the United States of Opioids and contributor to the Central Florida and UCF Project Opioid Report, Prescription for Change, Solutions for a Region. Harry, thank you so much, and we've been honored to have you in town.
It's really been a pleasure.
Again, if you're out there, his presentation is in a link below this video. And we'll put a link to your book as well on Amazon.
Fantastic.
In this as well. And also feel free to share this video far and wide. Thank you so much, and we'll be seeing you again soon. Connect with us at Project Opioid. Talk to you soon. Thank you.